malnutrition triggers inflammation because the body needs nutrients, body needs protein, body needs fats, body needs carbohydrate in certain percentage. When body doesn't, when your body is not getting it, then a sets of the control starts. Different types of cytokines, different types of mediators, different types of hormonal secretion starts, and they create a kind of inflammatory milieu. So it's always malnutrition and inflammation, and over a period of time, it becomes malnutrition inflammation syndrome, right? And that's called the malnutrition inflammation complex. And this syndrome, over a period of time, accelerate atherosclerosis, accelerate or difficult to control blood pressure is because of this, difficult to control sugar because of this, delayed wound healing, your compromised immune system, you're given vaccine, but you cannot produce antibody because your cells are not functioning. Someone gets the, suppose the influenza, same influenza you get, but you develop, or the CKD patient develop more severe symptoms, that require hospitalization because paralyzed immune system. These are the direct evidences of malnutrition, of the complications of malnutrition. So, one side, the malnutrition is doing a lot of things, a lot of maladjustment inside the body. And other end, you have causes of that, this. But there is no exaggeration in saying that ultimately what you see, a congestive heart failure and death, the heart attack and death, severe stroke and death, the severe infection and death, starting point was somewhere here, or the something which is connecting this to the end result from the initial disease is this, the malnutrition. The malnutrition, you can say if you control this, analyze it, correct it properly, so there are high chances that these complications you can avoid or delay it, or they would become much manageable. But what is happening in our society? Malnutrition, like we all are expert in our different field, but we all are all expert in nutrition and diet concern. Anybody who has just 12 pass, he is also expert in diet and nutrition. Because nobody gives, don't want to give it a thought. You are still, the nutrition means ye mat khao. This is the only the knowledge about diet and nutrition. I'm not talking about the general public. I'm talking about my own fraternity, my own colleague, my own seniors, my own contemporary. For them, the diet means you should not eat this. Kidney patient, they see, stop salt, प्रोटीन खाना बंद करो, नॉन वेज खाना बंद करो, तला हुआ बंद करो, एंड देन कार्बोहाइड्रेट बंद करो. सेकंड क्वेश्चन, तो खाएं क्या? नहीं नहीं ठीक है, बाकी सब खाओ. दैट्स ऑल. बट एक चीज जो सबके दिमाग में बहुत बुरी तरह से, इन पर्टिकुलर इन अवर पॉपुलेशन, ये एकदम हैमर्ड हो गई है कि प्रोटीन एंड किडनी डिजीज कैन नॉट गो. They are, the pole, the different poles apart. Protein means kidney failure. Kidney failure means you should not take protein at all. And it's causing whatever the complication I told you, malnutrition, inflammation syndrome, and accelerated atherosclerosis starting from here only. No one until unless you read that subject, none of us are dietitians. None of us are nutritionists, but we all behave exactly the same thing. Our prescription should be what? The first line should be like, because most of the time we deal with the lifestyle associated disease. We can say the diabetes, and all those. They have a genetic predisposition also, but the genes manifest when they get a proper kind of milieu. And one of this is lifestyle. So our prescription has nothing to do with lifestyle. Our prescription start from tablet this, tablet that, to number 20 tablet. But it doesn't start with the consultation with the dietitian, or our assessment starts with blood pressure, pulse, and saturation. Our assessment of patient is not going towards his, the hand grip strength, which is so simple to see, the muscle wasting, the BMI, which is not very difficult to see. Assessment of nutrition. Because uh, as a clinician, as a physician, our role is not to, uh, treat the values. Values means if the blood pressure is 160, 180, my aim is not to treat the value and then decrease it to 120. My aim is the someone who has come to me with a hypertension. I have to see what has caused hypertension is this, what of the complication this fellow has because of hypertension, and what should be the proper lifestyle adjustment, so that he would require minimum medication, right? It's not the salt restriction, it's not the protein restriction, it's much more beyond this, right? It's a beautiful study, the recently published, just like a meta-analysis. So it's like about 21 study, the big study, 10,000 people, subjects were taken into consideration. So what it says, the malnutrition and the mortality rate, the hazard ratio is so high and the p-value is so significant, you can see here. The bottom line is the malnourished dialysis patient has 49, you can say 50% higher risk of death compared to those with normal nutrition. Don't control their sugar, don't control their blood pressure, do not control their, the movements, or do not control, you cannot eat that, you cannot eat those things. Physical distance. Even if someone doesn't want dialysis, don't force them to go on to dialysis. But something which can be done is the nutritional assessment and nutritional therapy. That will give you much better result than sometime pushing the patient for dialysis. This is another beautiful study recently published. It says the patients who are admitted in the hospital, you can see the trend of malnourished patient in hospital outcome. The death rates are high, complications are much high, and the single important denominator is malnourishment. Uh, Causes of malnutrition in CKD. Uh, it's a complex subject, right? One hand you have kidney disease decreasing your appetite. You have nausea, whatever you are eating, it's not getting absorbed properly, and then you have complications associated like that. You have heart issues, you have paralysis, the blood pressure not coming under control, sugar tablet, you need multiple sugar level, or each tablet has its own problems. Because of all these things, you tend to have lower than required nutrition. This is the one side of the coin. The other side of the coin is over generous or totally wrong suggestions and misinformation given to the patient. We always say, do not do this, right? But we do not have answer then what to do, what to eat. If you ask me, I go somewhere and you ask me from tomorrow onward, you should start eating more pastas, more pizzas, more dragon fruit, something which I never had in my life in terms of 40, 50 years. From tomorrow onward, I am not going to accept it. But for say 10, 15 years, 10, 15 days, I can follow. I can follow for a month also. Someone who is predominantly, my staple diet is based on rice or on wheat. If you ask me tomorrow, the doctor says you don't eat wheat and don't eat rice from tomorrow onward. The patient will follow for 10 days. After that, he will not follow. He will follow half, or he will then substitute with other things. and always he would be in that guilt. Whatever is happening, and then the clinician has always a ready-made answer that you did not follow diet. That's the reason your kidney failure has progressed. That's the reason your health is not optimized. But we never look at from that angle that he is not eating because you have asked him. हमने उसको इतना डराया है कि वो रियल फूड भी नहीं खा पा रहा है. आपका फूड तो वो खा ही नहीं सकता है. He is in that tension. He is eating almost 20, 25 different medication also. And then family pressure, and then peer pressure, and then our society was was done. Everybody has done PhD in nutrition. So if someone can't eat this, don't eat this, eat with this, eat with that, and all those kind of things. Until unless we start considering diet as a part of our management, and it's a specialized subject. Like if someone comes to me and he has say about 16 years old or 18 years old, growth retardation, I won't write, though I know probably that fellow will need growth hormone stimulating factor. Probably I can investigate, but I will not. I will send this patient to an endocrinologist. Because I understand the importance of growth retardation. Similarly, a patient comes to you, you also have to make it a point to send him to a nutritionist or dietitian who can assess the patient properly, someone particularly who has multiple issues like heart failure, diabetes, blood pressure, this, that, coming from that particular group. And it's not only, I'm not talking about undernutrition, there's one another hand you have overnutrition, obesity and all. That's not the proper kind of nutrition we want. Excessive lipids, excessive carbohydrate. So both there needs understanding in the management. Right? Assessment of malnutrition, it's not a the very big ticket things. Like there are multiple tools available. There's one simple thing which we can do in our OPD on the that's called the must calculation based on all those three four simple things. The must tool this we can keep in our OPDs and then assess each of our patient, particularly all those patients who are coming to you since number of years and they have complications, complication related to eating, maybe under nutrition, over nutrition, both can be assessed. And then if you want to be very specific, then all this other assessment tools are also there. But it's not impractical, first of all, very costly. If we do BIA, for example, biometric bioimpedance analysis, the machine cost is around 20 lakhs. The machine cost is 20 lakhs, people are using it. Why they are using it? Because they know the importance of assessment. They want to know that how much is the percentage of fat, how much is the percentage of muscle, how much is the percentage, or how are the mineralization of the bone. That's the reason the company has come with the 20-25 lakhs machine. Similarly, DEXA machine. It's like one-time investment. We will come to know so many things about the patients. What particularly when we talk about the chronic kidney disease, if you look at the patient, it would be very difficult to understand that the patient is malnourished or patient is obese because in kidney failure there's a huge change, alteration in body composition, the muscles, fats, and the water. Until unless the patient has regained near about 5 to 6 liters of water, you won't even come to know there won't be any swelling anywhere. Right? 5-6 liters of extra water, it's there in the body. The patient's weight may remain stable, but the fat has lost, the muscle mass has lost, and what he has regained is just all water. Right? So, few latest guidelines on renal on CK. Simple. It's actually it's a full day discussion. There's a big books on it. There are so many other things, so many nitty gritty. But if you look at this, there is no blanket, some kind of judgment. You cannot do this. There is no guideline says that you cannot eat non-veg, for example. No guideline says you cannot eat fruits. No guideline says you cannot eat carbohydrate. What guideline says you have to modify, you have to adjust, you have to individualize. Look at this early CKD. First of all, CKD risk factor, so that's okay. Common diabetes, hypertension, all those things. Early CKD, it's only reduced salt intake. Not nothing much. Saturated fats, any which way, many of us are not eating. For early CKD means stable GFR is more than 30. Early CKD, it's only reduction in salt is more than enough. But simultaneously, what it is suggesting, more of fruits and vegetables. You can have proteins. You can have a non-veg protein as well. You can have veg protein also. It does not say that you have to stop it. And then comes the GFR has declined. The basic idea, because I don't know if you remember it or not, since 20 years, we'll be knowing the 20 years before anybody has liver problem. Liver failure means no protein. No protein means no protein. Liver failure, no protein. The scenario, because I have worked also, anybody comes with liver failure, we will do from that time onward till that patient dies, no protein. That was the thing that we used to write in bold letter in our papers, right? See, 20 years down the line, now any patient with liver failure come, what we say, more protein, right? So their understanding has grown up. Here, still, we are lagging behind. Look at the guidelines. Initial stages, proteins are allowed, only salt intake has to be reduced. And later on, protein should be limited. Why? What protein does to the kidney? Because the protein is something which has an amino group that cannot be excreted from the carbohydrate and fats eventually converts into carbon dioxide and water. So carbon dioxide can come out from the lungs and the water from the GI tract or from sweat as well as in the urine also. That amino group requires it so that it can come out. And if you give more protein, the kidney needs to work more probably, and there would be vasodilatation, or the failing kidney will fail faster. This was the concept, but this was the concept generated from the West because their basic diet is non-veg and more protein. That we cannot copy and the paste same thing in our society because we are basically more of fruits and vegetables and the good. Actually, our food is very good. If you compare the best diet of the world, do you know what is that? Anyone? There is a country called Norway and all this Mediterranean place. So Mediterranean food is considered the best food. Uh, don't know the logic behind, but they have seen the people of that reason they have longer lifespan and minimum lifestyle associated problems like diabetes, hypertension. Well, it's not that they do not have, but compared to the people who are on Western side. So their diet is basically based on lots of fruits, lots of vegetable, lots of milk and milk product, lots of lean meat like fish, eggs, even yolk, everything good oil, even ghee for that matter, in our Indian context, their diet is predominantly that. And it is considered one of the best diet. And those people, and here, we are also predominantly a plant-based food eating society. That's if you look at the what our grandparents used to eat, it was fantastic thing. Like other day, I was thinking, ki, हम लोग जो रूटीनली खाना खाते हैं उसमें कौन सा विटामिन है जो रूटीनली हम लोग नहीं ले पाते हैं. There are two vitamins. One is, in fact, three. Vitamin D, because हमारा भी sun exposure बहुत कम हो गया है. लेकिन अगर कोई predominantly vegetarian है तो vitamin B12. That is very limited because that's found, that is actually more in the non-veg stuff. And then comes the vitamin C. Right? Vitamin C, there are few things which are very rich in, few plant-based food rich in vitamin C, but it's not a part of our regular routine. Go back 50 years before, you used to have that lemon, every day, or you used to sprinkle lemon in our. You used to make chutneys of pudina. You used to make chutneys of Indian gooseberry या आंवला का चटनी बनाते थे, मिर्ची का चटनी बनाते थे, उसमें हम नींबू डालते थे. वो सब कहाँ गया? वो तो fantastic thing because it has vitamin C in pure form, because if you cook, the vitamin C will destroy. The fantastic thing there, it has, vitamin C, it has iron, or vitamin C, iron needs vitamin C for absorption. You have this, just a small, teaspoonful of that, you will get your possible amount of vitamin C and vitamin B12. We have forgotten that. Coming back to vitamin D, now we are resorting onto the supplement. But for 10-15 days of getting up early in the morning, going, probably, I don't know, or maybe I'm probably over reacting. That Surya Namaskar is also for that, the 15 years in 15 minutes in front of this one, Surya Bhagwan, and that will give us enough vitamin. So the little thing which could have carried forward, but we have stopped doing that because of our literature, particularly the allopathic literature, is heavily bending towards the West, and there also, whatever they say, it's 100% sure. It's still not there because most of the evidences, if you see, that is 2C evidences, 2D evidences, 2A, hardly anything which is 1A, 1B, right? So number of things which we could have we could have adopted, but we have not. So couple of things, medical nutrition theory, just something. I'll finish in 2-3 slides. When it comes to kidney failure, all of us say fruits and vegetables should not be, or particularly fruits should not be taken. What guidelines say we should take more fruits and vegetables in early stages of kidney failure, before GFR is before 30, say above 30. Fruits and vegetables, even if there are multiple studies, if you eat fruits and vegetables, you would not require soda bicarb. Soda bicarb routinely we give to the patient. You would not need that. You would, because of the then uremia generation will also reduce. The urea level will come down because of the fiber which fruits and vegetables have. They will increase the gut transit time of your food, right? So the bacteria and the harmful bacteria would not have much time to flourish there. The natural ingredient in fruits and vegetables will provide you enough bicarbonate to counter the acidosis which is generating because of the CKD. It says good amount of fruits and vegetables you would not require. And the other advantages of fruits and vegetables, your blood pressure will come under control quickly, your diabetes would be properly managed. So fruits and vegetable is not contraindication in kidney failure. The similarly, protein intake. We say no to protein, or in general, we say 0.6 to 0.8 grams per kilogram of body weight protein should be taken. The diabetic patient little high. Even we do not take that much. But the problem doesn't lie here. Problem lies when you say do not take protein. Whenever you are saying do not take protein, then it automatically it becomes your responsibility that if you have advised someone that should not take protein, And because of not taking protein, the patient has developed severe protein energy malnutrition. So that's your duty to constantly observing or analyze that patient, constantly assess that patient. Merely saying do not eat protein means you can say you don't go in that direction, and then you back off. But if that fellow is not going in that direction, which direction is he going? That's also our job as a clinician. So if you say do not eat anything, you have to also tell them what to eat. And when you say what to eat, you cannot just copy and paste the menu from somewhere else. You have to modify whatever that fellow is eating or fond of eating according to his taste and the local culture and all. So then it becomes a complete, the suggestion. Energy intake also, it's not that you have to reduce everything. Energy and calorie and the carbohydrate, all are very important. The carbohydrate intake. Obviously, if someone will not eat protein, someone will not eat fats, then the extra amount of calorie he has to take carbohydrate. So what type of carbohydrate? The complex carbohydrate is good, and then everybody should kidney failure should be encouraged to take. Does medical, because nowadays everybody asks for evidences and the proof, does medical nutritional intervention, and it's medical nutritional intervention is a big one. Basically, if you have analyzed your analysis of patient doesn't uh, uh, stop until and unless you have analyzed the nutritional status of the patient. That should be a part and parcel of everyday examination of the patient. And once you see any deficiency or excess of nutrient, both, and then you should involve, or you should develop the taste to evolve yourself and understand what is diet, what is nutrition, and then provide that. And does it helps? It does. It's a beautiful study. It shows the mortality, the ratio, everything comes from. There are multiple papers on this. Will not go on that. So the bottom line is, my in my country, in our country, the kidney failure patients are dying much before than the kidney failure patient died in the developed country. And what is the common thing is malnutrition, which is very prevalent in our society. And other common thing is the wrong information, the wrong suggestion given by the public, given by our colleague also, in most of the cases. So if we want to stop early deaths or premature death in our chronic kidney patients, so first we have to start from the nutritional intervention. That's a very important aspect. So for that only, we are planning to start. We have taken up a project that's called the Nourish. Stands for this. In Nourish, we will not only in this center, but the project we will try like to implement in other dialysis centers with other chronic kidney disease patients. Will assess nutrition, and then our emphasis would be on locally available, easily digestible food items. The consumption of all these food items should be encouraged. We would encourage in multiple ways, or let's see how it would be done. You see, the locally available food items costing just nothing, but having good amount of proteins, good amount of other important nutrients. So the project Nourish would be started very soon in our department, and I'm testing if it provides something good, then definitely we'll implement in other sector also. And for the project Nourish, we all need your support. Thank you for the patient.
Thank you, sir, for an enlightening session. So many myths which we have and we carry since years together has been broken. I would request Dr. Raksha to kindly hand over shawl and shriffle to sir as a token of appreciation from Dhavli Trust Hospital. Thank you so much, sir. Be back upon you. The center is always dependent upon you, and the wise wisdom which you have always taught us is always guiding. Thank you. I would request Dr. Sapna to kindly felicitate our ex-RMO of Dialysis Center and now a member of MFFDA, the Dr. Dharti. Ma'am, please. Thank you, ma'am. I would request, sir, I would request Dr. Sapna to felicitate our orthopedic surgeon, Dr. Prakash Gursurkar also. He has joined us. Sir, please. Thank you, sir. Thank you for joining us. Thank you. Now we have heard something about the malnutrition. In that line, we have conducted a survey of malnutrition amongst our in-house dialysis ESRD patients. But before presenting the survey findings, I would like to thank Dr. Bharti Shah. She has been a great inspiration. Dr. Kideny has also joined us at the very beginning to help us. They have helped us, our students, they have trained our students how to take anthropometric studies. And I would also thank research department for providing us bioimpedance machine. And thank you, Dr. Devangini, thank you, Prashant sir, and thank you even Dr. Tanmay. I would thank all my residents of nephrology unit. They have done a tremendous job. Special thanks to Dr. Trupti. She has single-handedly done all the TSF findings. So, because without you, this survey I would have not done. This survey was completed within a span of 8 days. It was analyzed and now it is getting presented. So it's a huge work, and I tell you, I have not I've slept at 3 a.m., 4 a.m. since 1 week to present these findings for you. So thank you all. A need of survey sir has already covered, so I will skip those parts because malnutrition is one of the greatest mortality factor. So what we have done, we have enrolled all the patients. Currently we have 43 patients, out of which 40 we have enrolled because 3 patients were very bad, so they were not here. They were transferred to tertiary care center. One patient out of this 40 had an amputated leg, so he could not stand on that bioimpedance machine, and hence his reading could not be taken. So we have not done the bioimpedance of that patient. There are other methods which Madam will also tell you how to understand the malnutrition in that patient as well. So the patients were inquired about the essential preliminaries like age, and everything. Bioimpedance machine readings were taken, anthropometric measures were carried out using vernier calipers, hand grip machine, and the data was correlated with 24-hour diet recall. And all the interpretations we have just given the Excel sheet to Madam. It was 108 columns, and it was a huge Excel sheet of 39 patients. And Madam has analyzed it in within 2 days. So she has done all the interpretations. So these are the observations. Male and female split is there. 51% female and 48% male. So its sample is relatively balanced. Young adults, we can see the age-wise distribution. 15% were between the age group of 18 to 35, and middle age were 36 to 55 years. Senior citizens were 50%, and 56 to 75 years. So distribution of serum sodium, you can see 134 is the mean value of serum sodium in these patients. HB is quite low. We have a 9.4 as the mean value of HB in these patients. So high anemia is linked with even difficult years for these patients and difficult quality of life as well. Now this is even sir will agree. Our dialysis patients do not follow the diet properly. serum potassium is the major threat and a major headache for all of us. The serum potassium is whooping high, more than 6, 7, 8. This is too much for our patients. They do not listen also. Serum phosphorus, see the levels. 6 on 7 patients have more than 6, 7 phosphorus level. More than 4 is greater. Albumin is quite low. When you see the value, you can have a mean of 3.5 in these patients. So we have a low albumin, a borderline albumin in these patients. Distribution of BMI, we have around 25 to 30, 30 very less. So 25, 30 BMI is not a major issue, because even sir has also told that uh, I will I will explain this in other slides as well. See the creatinine. One person has an isolated value of 1 in creatinine. The creatinine was 18 because he's not taking dialysis as required. The dialysis dose is not properly going because of his end. He cannot meet because dialysis and CKD is very complex. The monetary and social factors do overpower the intelligence of the patient and even sometimes our intelligence. These are the distribution across the albumin, hemoglobin, and BMI classification, which I already told. This is a statistical summary of the duration of CKD. So we have patients ranging from 1 to 14 years, they are taking dialysis. So this is the main variation. So median year is 3 years. And observation is this bracket is 1 to 5 year, which we have our the major bracket. Major comorbidities are seen as diabetes and blood pressure, followed by cardiac issues. So this is the BMI classification which I told you. We have majority chunk in the normal value. We have 26% patients who are underweight. We have a 23% patients who are at risk of high BMI. So what sir was telling, obesity, you don't understand. You think muscle mass is so much and the patient is very obese. He's okay. No, it is not like that. So the things are other way around. TSF risk category, the triceps thickness is very, very less in these patients. So mild to moderate fat loss is there in these patients. Hand grip test is one of the major things. उनमें जान ही नहीं है ही they are very less, far less than our expectation. 8 kg, 9 kg, 10 kg was the mean value. So that is very, very less. The males are generally showed higher grip strength than females, but difference was not statistically significant as p-value was 0.087. Both genders are equally affected with muscle weakness, which is common in advanced renal diseases. This is fat and body water distribution. Body water has gone behind. So fat, you can see normal we have 71%, high fat in 14 and low fat in 14%. This is the distribution without fat. So 20 kgs, at least I can say 15 to 20 kgs person is carrying fat. That too subcutaneous fat, that is too high. Okay. Subcutaneous fat, you can see the percentage, 30% have more subcutaneous fat than expected. This is the muscle mass percentage and visceral fat percentage, where visceral we have less because, but when we see the muscle mass interpretation, normal we have 37% and sarcopenic is very high, 56% just by this muscle mass and bioimpedance calculation. Meal pattern and food intake, everybody is regular in their food intake as per them and they have a very good appetite, but still patients are malnourished. So another thing is a chronic inflammation which is going on in the background is one of the things which we need to address in these patients. So this is the BMR of all the patients. Our average range we have 1,500 to 1,200. Functional capacity is normal, but 48% have shown that they get tired after they work, and 10% they don't have energy to even move after dialysis. Weight loss, 77% told that we don't have a major weight loss in the past 6 months. Fat without weight, I have already told. Fat loss evidence, you can see. This is the SGA analysis, which is a nutritional status analysis, subjective global assessment, and as a primary tool to classify the nutritional status. Severely malnourished 50% patients, that is 16 patients, a very high amount, even alarming for us. Mild to moderate malnourished in 43. So you can understand 93% people are malnourished at our center. well nourished is only 6.2%. That is only two patients. So this is a very alarming thing, and this is carried out at a very small sample size. You just imagine 2.1 million population who is entering the dialysis is entering with this malnourishment. So that is why the conclusions I have already told. Most significant findings: 93% study is in favor of malnutrition, 50% severely, 43 moderately, and 3 patients were well nourished. BMI, fallacy, and sarcopenic obesity is one of the things which I want even the students. We had Dr. Priyadarshini also from PD Hinduja joining us for our nutrition when we were conducting the basic level course. So you will remember even she was on back behind that we should increase the protein intake and more protein in the CKD patient because of high protein loss. So the study proves that BMI is misleading indicator in the health of ESRD patient, which even sir has told. Okay, overweight and obese were still diagnosed severely malnourished by SGA global assessment, and this confirms the sarcopenic obesity, where high body fat masks the skeletal muscle mass. Okay, so this is the correlation. Others are I have already told. So I will just in summary, this highlights the malnutrition in ESRD patient, and the cohort which we are taking requires a weight monitoring, a shift from only weight monitoring to the body composition monitoring. This is a high time that we shift this because things are not going like that. Is why we all are here discussing the malnourishment in this patient, which is the highest contributor, even sir told, highest contributor of mortality. So we have a lot of plans to do. So I will even take a moment to tell what other things which we are going to do in future and currently which we are doing. So this is the way in which we do the holistic integrated care of patient at our dialysis center. So I'll go very fast with this. You all know that the disease is not only just a mere disease entity, but it requires mental, physical, social, and spiritual. It's an integration of from the biomedical model to biopsychosocial model, and it's a dynamic phenomena. And how DTH offers this holistic care, all the patients are under the standard modern medicine line of treatment as well as our homeopathic care. So I can say around 95% patients are receiving the integrated care. So that takes care of everything, the social thing, the even we have started the care of caregiver project because caring for a dialysis patient is another major task. So in this way, the homeopathy offers an excellent way for a holistic approach. We provide for the information of GPs and all attending. We are well equipped with the dialysis center and a well-established RO plant with weekly monitoring and maintenance. Currently, we have 60 patients and 45 patients in MJPJY. Currently, now this is the statistics of last year. We have now currently 50 patients. Okay. CT scan USG are done at a regular interval. We work in 2 shifts. From the well-equipped expert technicians render services for 8 to 10 hours. Plus, if any patient you have at your at your notice, you can send for emergency dialysis. We work for all 24 hours as well and provide emergency dialysis. We have a visit to nephrologist. All the constitutional homeopathic medicines are given to the patients, which benefit them and post-dialysis symptoms reduced. Care of caregiver project is also taken. The services which we provide is dialysis catheterization, both permanent and temporary both. So we are into that. We do IPD admission of CKD, AKI, and ESRD patient, and management is under nephrologist care. We have even started kidney biopsy from this year, and we have done few in the last year as well. So we offer kidney biopsy services as well. So now I just want to take a brief research projects which our department has undertaken. I am currently doing my PhD thesis also in this, where I will be exploring the action of integrated homeopathic medicine as an add-on palliative therapy among ESRD patients through a symptom distress inventory. It's an uncontrolled experimental study design. Other MDPCs which we have taken are understanding the group of homeopathic remedies with emphasis on interpersonal relationship. This is taken by Dr. Keshav from the psychiatry department. We have another application of BPS model, biopsychosocial. Homeopaths will understand this in the totality formulation of end-stage renal disease. This student is doing thesis under me, and I have another. We have undertaken because we want to start at the preventable beginning. So this year we have another student, Dr. Gauri, who is taking the project of understanding evolution and progress of CKD from grade 1 to 4 and its miasmatic evolution and impact in the homeopathic management, a retrospective case series. So along with this, it is my great pleasure that learner care, because try coordinate care is our motto. So learner care, we have started with a certificate course in homeopathic management of CKD and ESRD patients of our residents, and many of the residents are here who have been the part. Can you raise your hands? Yes, thank you, thank you. So they have been the part of this all. They have completed their basic levels, and 13, 14 people have even cleared the advanced level. We are involved. We have involved the patients in the recent survey, which I told you. So this is the thing which we are doing. Thank you so much for the patient listening. Now I would call upon our second speaker, Dr. Bharti Shah, upon the podium.
We have one question from Dr. Jalaram sir.
Yeah. Okay. We would have the question answer round after the. It would be okay. We would have a question answer round after the madam's presentation. Question answer. Thank you, Abhishek. He has been helping me a lot for the technical difficulties through you understand the math and the compatibility of math. So I would now introduce you to the our recently joined resource person to MLD-MHI, dietitian and clinical nutritionist of Nutrop Clinic, Kandivali West. She's a PhD MSc Food Science and Nutrition. She has done PG Diploma in Dietetics. She's even a homeopath and UGC NET and SET qualified physician. Okay, so we move forward towards her professional journey. She's a dietitian and clinical nutritionist. She's a professor over 15 years of clinical experience as a dietitian and clinical nutritionist. More than 6 years of postgraduate teaching at SNDT Women's University. She's currently a clinical nutritionist and research associate at Kasturba Integrative Health Science Medical Research Foundation, Mumbai. She's even examiner and paper setter at SVT College of Home Science, Mumbai. She is a resource person. She was invited at Mantralaya also on occasions of Women's Day to address the importance of women health, focusing on balanced nutrition and preventive care. So thank you so much. It's a great pleasure to have ma'am with us. And I would tell that ma'am has done a tremendous job in analyzing the great, huge Excel sheet. So thank you so much. Thank you so much. Yeah, thank you, ma'am. It's your generosity, but without you, we could not interpret it. And I think it is marvelous to do anything within a week span. So thank you. I would hand over till we adjust ma'am's presentation. We can take over Jalaram sir's question. And, so the question is, SLE patient mostly die with nephritis. In malnourished SLE patient with creatinine being normal, with fetal edema, what diet should be advised? Or renal transplant is the best option? What other treatment line is available to prolong life?
SLE patient with normal creatinine and swelling, then again it pointing towards low albumin or probably nephrotic syndrome, because many a times you would have a significant proteinuria and still the GFR or the filtration is preserved. Significant proteinuria definitely will cause malnutrition at some point of the time. For such type of patient, you have to give more protein. So, how do you calculate? Uh, Normal person requires 0.8 to 1 grams per kilogram of body weight protein. If someone has only proteinuria, filtration is still intact, so no need of reducing protein. You have to continue the whatever we give to the general society plus the 50% of the protein sheets or that the person is losing in the urine. Suppose it's like 3 grams protein losing every day. So we have to give at least 1.5 grams over and above the person normal requirement. As far as renal replacement is concerned, it entirely depends on the primary cause. If SLE is active, we cannot do renal transplant. SLE has to be inactive at least minimum for 1 year. Previously, we used to say 2 years, but at least for 1 year, there should not be any activity of SLE. All DSDNA titer, complements level, everything should be in the normal range. If disease is inactive, then patient can be taken up for the transplant.
Any other question from audience? Students, do you have any questions? Okay, so we are on. Till the time we arrange and sort out the technical difficulties, I would like to tell about something about our kidney course. It started? Let me tell something about our kidney course. It ranged from anatomy, physiology, pathology, and it correlated the clinico-pathological miasmatic correlation. It had a variety of renal pathologies which were taught to students. Right from anatomy, we have started and we have gone to the advanced kidney failures, AKI, autoimmune diseases, and uh, and transplant, how to do the peritoneal dialysis, what are the risk benefits, plus the homeopathic care and forming a totality, reaching the miasmatic level, prescribing a correct intercurrent, and prescribing a understanding of correct posology in these patients. So that has been taken up. There were 30 students who have enrolled into it from the start, out of which only 14 were eligible for advanced exam. So 14 students have cleared those exams. So many congratulations to them. We are going to felicitate them as well after madam's presentation. So all hand over to ma'am. Thank you so much. Good afternoon, everyone. Hello. Yeah, good afternoon, everyone. Respected dignitaries and all doctors. Before starting my speech, I would like to express my sincere
thanks to Dhawle Trust Hospital, especially Dr. Kumar Dhawle sir, Dr. Prashant sir, and other team members, and Dr. Namrata to providing me this platform. And so we are here to celebrate World Kidney Day 2026. So World Kidney Day itself, it suggests that here we have come together for the preventive care and the early diagnosis as well as the awareness about the kidney health amongst healthcare practitioners as well as amongst the patients and their relatives. So, nourishing kidneys and saving lives. This. Hello. So nourishing kidneys and saving their lives. So identifying and addressing malnutrition. So Dr. Prasad sir actually excellently gave a very informative session. So thank you sir. You have made my own presentation much easier. So I would not speak more about the malnutrition and causes. My aim is to just focus on the nutrition aspects, how we can assess the malnutrition with the help of the latest nutrition score, that is SGA, which we conducted here on the in dialysis center. So role of nutrition. This is about the statistics. Already, sir as well as Namrata madam have just now addressed that 13.22% of Indians they are suffering from CKD, and majority of the contributing factors are diabetes, followed by hypertension, then infection, inflammation, and of course there are hormonal changes also. So, malnutrition is common in end-stage renal disease. So, basically, what is malnutrition? Malnutrition in CKD or ESRD, the protein energy wasting (PEW), which is the sole reason for increased mortality as well as the morbidity. So, it leads to poor quality of life and higher hospitalization rate. Now, this is very self-explanatory, and already sir has explained. These are the various factors or causes of protein and energy wasting, inflammation, comorbidity, poor dietary intake, especially due to anorexia. Patient is not feels to eat, or and because of the metabolic acidosis as well as the uremia, this protein energy wasting is occurring. Now, basically, what is protein energy? This thing, low muscle mass, low fat, loss of energy reserve, leading to functional decline, impaired quality of life, and functional capacity. That's why we have used subjective global assessment tool over here at dialysis center to address to diagnose the malnutrition in patients. So metabolic acidosis, very big pathophysiology behind acidosis. Just in a brief, if we can, acidosis eats muscles. That means nephrons are not functioning. Because of that, there is a damage to kidney, increased acid accumulation. It further leads to protein breakdown and then the muscle loss. So there is how we can assess if the person is. We should start the nutrition assessment before dialysis. If the person is less than 50 years of age, then the assessment should be every 6 months. If more than 50 years and it is the person is on the maintenance dialysis, then of course we have to do every 3 months. Now, these are the few multimodal assessment. So, in our nutrition language A, B, C, D, anthropometric, biochemical, clinical, and dietary. And subjective global assessment, malnutrition inflammation score, and dialysis malnutrition score. So, dialysis malnutrition score it is the advance of subjective global assessment. But globally, subjective global assessment is utilized. So what is there in the anthropometry? So many of the things we have conducted here, we have taken help of all this anthropometry. So BMI, mid-arm circumference, pinfold thickness, hand grip strength, which is the functional marker, as well as the fluid. For all these things, as sir has also suggested that overload of fluid or fluid retention, water retention will be the limitation of anthropometric measurement. Biomarkers, serum albumin, pre-albumin, transferring cholesterol, and serum creatinine. Dietary assessment, there are varieties of dietary assessment. 24 hours recall, food frequency questionnaire, protein intake estimation, and calorie estimation. Advanced tool, already sir has suggested BIA and DEXA. DEXA is very expensive. BIA, definitely we can take help of BIA. So what is the subjective global assessment? It has the 7 components: weight change, dietary intake, GI symptoms, functional capacity, disease metabolic state, that means the comorbidity of that patient, subcutaneous fat, physical examination, that means whether muscle or fat loss is there or no. Already you have come to idea. Dr. Namrata has shown the diagram, bar graph, where we have got the muscle loss, fat loss, subcutaneous fat loss, and TSF also. Scoring is there. If patient is well nourished, the scoring will be 6 to 7. If the score is 3 to 5, mild to moderate malnutrition. And if the score is 1 to 2, severe malnutrition. Malnutrition inflammation score, it requires the biochemical parameters like total iron binding capacity, and here also scoring is there. Now, so for protein energy wasting, at least 3 of the markers should be there: either body mass, muscle mass, dietary intake, biochemical markers. So initially, I'm just explaining what is the assessment, how we can assess the malnutrition. Now, hence, afterwards, I will be explaining the medical nutrition therapy. And definitely, I am also going to provide the recipes. Sir has suggested that people are just telling, even doctors, laymen, or dietitian, that you are not supposed to eat this. But I am going to give the more recipes that what the person should eat, especially the CKD and ESRD and malnutrition. So serum albumin, 3.5 to 5 gram per DL. We know it is a normal marker, but 3 to 3.4, that means early malnutrition or inflammation score. So what may be the nutrition strategy over here? So high protein. As earlier, it is suggested that you sir told us that protein है अरे बाबा sorry, renal disease है कम protein खाओ. No, it is not like that. कम protein नहीं, high biological, less protein, but it should be of the high biological value protein. 50 to 70% of the high biological value protein should be given. So what is high biological value protein? Ideally, I have written here the non-vegetarian sources like egg white or whole egg, chicken, lean meat or fish. But suppose a person is vegetarian. So do you know what is the options or recipes of the high biological value protein in vegetarian sources? Anyone knows?
Soya bean,
Okay, soya bean.
paneer.
See, traditional, our ancestors were very, actually highly intelligent. They were eating khichdi,
Moong and rajma.
okay. See, the rice is limiting in one amino acid, lysine, and dal in methionine. So when we combine together, we get the high biological value protein, that is the khichdi. Why we eat idli dosa? South Indian cuisine excellent. Why we eat idli dosa? Then Gujaratis white tokla and khichdi. They are the combination of cereal pulse combination. Here, if we can eat with the curd, then you will also get the B12. So khichdi, dal, dokla, but use moong dal in case of renal patient and avoid the whole pulses and too much of sprouts. So serum priya, we are going to what I am going to explain you the first markers which are responsible for protein energy wasting. So we have seen pre albumin. Now pre-albumin, it is the short-term marker of nutrition status. So before dialysis, we are doing blood test. We know what is the pre-albumin as well as the albumin status. So pre-albumin status, if it is low, then definitely there is the protein energy wasting, especially low protein, and we can detect early malnutrition. So it is a kind of a prevention therapy rather than the medical nutrition therapy. If we detect early malnutrition, we give the proper nutrition strategy, then it shows the improvement within days or weeks, and also prognostic marker. If the person is suffering from the high severely malnourished patient, if we correct with the high biological value protein, if at all required supplement under the guidance of nephrologist, then definitely prognostic importance is also there. So serum creatinine and creatinine index, again, it is a good marker of protein energy nutritional status because it is correlated with skeletal muscle mass loss. Now cholesterol level, as we know that for layman as well as the for the any disease person, 200 milligram per dl, less than 200 milligram per dl, which is the acceptable range. Here, if that is below 150, then also it suggests protein energy wasting. What happens in our survey? We have seen that patients are eating. Two patients, they are not malnourished. They are eating energy, but they are not eating the proper all balanced diet and the high biological value protein. That is why some or other parameters are not matching with the normal parameters. Now from here, this slide onwards, all medical nutrition therapy as well as the diet related things I am going to explain. So, since 3 to 5, no diabetes mellitus, protein 0.5 to zero point 0.6. Suppose person is on dialysis, which is the fifth category, then 1 to 1.2 gram per kg body weight of protein is required. That means if person is 80 kg, then 80 multiply 1, that means 80 gram of protein per day. And in that, 50 to 70% should be the high biological value protein. And this is for the hemodialysis. For peritoneal dialysis, you can go higher, that is up to 1.3 gram per kg body weight or even higher as per the requirement. So this is regarding the energy. Energy also should be 30 to 35 kilocalorie. Again, see, all diets are always individualized diet. Though person is suffering, five patients are suffering from CKD or ESRD or malnutrition, they all require the individualized precision diet because there the requirement as per body height and disease condition is different. Okay. So I'm telling you about the energy, how we can calculate energy, especially in the renal cases. So suppose I'm a normal person, I'm not having CKD. So on my current, whatever my ideal body weight, according to height and this thing, I can calculate my energy. But in case of renal patient is having pedal edema or water retention. So these are the types of the diet. So actual body weight, which is the current weight. Ideal body weight, it is on the basis of gender, height and weight. The third category, usual body weight, that means it is through the patient's weight obtained through previous measurement or history. Edema-free body weight, that means the dry weight. Over here, Dr. Namrata, we have calculated on the basis of dry weight, correct?
Yes, yes.
Yes. And then adjusted edema-free body weight. Ideally, we should calculate energy as per the adjusted edema-free body weight. It has a certain formula. So I will show you how we dietitian or nutrition is calculating energy requirement for malnourished ESRD patients, especially on the dialysis. So this is the formula. This is just example, 40-year female, height 170, 80 kg. How we are calculating IBW, height 1 minus 154. Everything is mentioned on right side of block by 50 kg in male and by 45.5 kg in male. So once we get the IBW, then after IBW, we can calculate the adjusted body weight because we have to give the accurate energy and then we have to give the accurate protein requirement of that patient. So finally, adjusted body weight is actual weight minus IBW multiplied by 0.38 plus IBW. What is here 0.38? It represents the estimated proportion of excess body weight. We want exact correct body weight. So energy will be the 35 because this is the malnourished patient. So 35 multiplied by person's adjusted body weight 67.5. So I will get the energy 2360 kilocalorie per day. That means my patient, she is female 40 years, she requires exactly 2363 calorie per day. So next will be regarding the protein. Now I will be explaining macronutrient, energy, protein, then later on the micronutrient. So protein intake, as I already mentioned, so this is the myth, like protein restriction is not needed in dialysis patient. So हम लोग अभी सर ने भी चिल्ला के बोला, मैं भी बोल रही हूँ कि protein restriction is not required. Protein high biological value as per that person's malnourished condition, as per that person's SGS score or functional capacity. We need to see all parameters and then we can decide the menu. So, regarding the protein energy, protein thing. So, portion control is very important. I hope everyone knows what is serving size and portion size. Serving size is what is recommended for you. You eat two roti, that is serving size. But if you eat four rotis or four paratha out of your liking, that would be your portion control. So, portion control is very important here. If you see the chicken, in that breast contains highest protein and least protein is there in the breast wing. So if patient knows, even if doctor knows all these things, then definitely dietitian or patient or relatives can combine all these things and prepare the proper menu or recipe. And regarding on right side, I have mentioned quantity of protein in that particular item. Egg white. Egg white is the best source of high biological value protein which contain less phosphorus. So in the CKD as well as in ESRD, we need to consider three things: sodium, potassium, phosphorus, apart from protein also. So paneer, milk, curd should be used in a restricted amount, considering the person's phosphorus level, because all milk products they are high in phosphorus. So dal, half cup, 5 to 6 gram protein. If you see the average, one recipe should give between the 6 to 8 gram of protein. Okay. So example, if the weight is 68 kg on and person is on maintenance of hemodialysis, then my goal will be the 81.6 gram protein per day. So what will be the person's patient will be asking. Here also patient was asking, आप मुझे बताओ मैं पूरे दिन में क्या खाऊं, कौन सा प्रोटीन खाऊं, दाल खा खा के थक गई हूँ या थक गया हूँ. So here there are the varieties. Half cup milk. Again check the phosphorus limit. 4 egg whites, 60 gram of any meat or lean fish, 3 servings, that is approximate 250 to 300 gram of vegetables. Vegetables should be of the low potassium, all raw vegetables. Dudi, bhopla, all those raw vegetables which we actually, general population doesn't like that. Raw vegetables बोले करेले बोला तो नहीं but this patient ideally requires. Then 8 servings of grains. Why grains? Because it provides vitamin B as well as it provides fiber also. Okay, so these are the different types of diet. First is a just pure vegetarian diet. Okay, no milk product. Then second will be the vegetarian diet, which includes dairy plus egg. Now pesco vegetarian diet, which includes dairy, egg, and seafood. So in second there is no seafood. In third category there is seafood along with dairy. Fourth lacto vegetarian, which excludes eggs. Fifth ovo vegetarian, so vegetarian but excludes dairy. And the last category, it is the based on the purely plant origin. These are the types of diet. Okay, so fiber, regarding fiber, Dr. Prasad has excellently said that it really helps to remove the excess cholesterol. It binds the cholesterol, it increases the transit time, and it helps to remove the cholesterol. Along with that, it also helps to facilitating the colonic elimination of potassium and thus protecting against the hyperkalemia. Because in kidney planning diet for kidney patient is very tricky for our dietitian. कोई भी बॉडी का सिस्टम ले लो, हम इजीली डाइट बना पाएंगे, बट रीनल पेशेंट आता है तो हमें 1 घंटा 2 घंटा या आधा दिन भी लग जाता है. If the person is on the water restriction, so we have to need to take care of potassium, phosphorus, sodium, so many things. This one is not
अच्छा.
Okay, so another concern regarding intradialytic weight gain. Why intradialytic weight gain? Main cause is the sodium. I have seen here also patient. I asked the diet recall. They were just eating the 10 rupees ka this chakri, tomato chakri, then biscuits. See, all are processed and packaged food. When the packaged food, that means highly processed. It comes with it loaded with the potassium, sodium, and so many harmful things as far as the kidney patient is concerned. Control fluid intake, thirst management. So thirst management strategy would be this: 2 gram of salt. So if you go to the any hotel or something, you get this 1 gram of session. This is the 1 gram. So if the person is severely malnourished, very high scoring of this CKDA, just give them this is 1 gram. So 2 gram is sufficient. Okay. So this way we can tell them how to control this salt or sodium. Thirst management, if the person is feeling very thirsty, then ask person to just keep ice on the lips. Do not swallow that ice or do not swallow the water. So there are the and limit the sodium. Once you limit the sodium during dialysis, then it will help to reduce the intradialytic weight gain. So these are the thirst management strategies. Spread fluids across the day. So what is my strategy for diabetes patient? I say distribute carbohydrate evenly throughout the day. Okay, एक बार में 6 चपाती मत खाओ, 6 चपाती एक बार में 2 खाओ, बाकी की 4 डिस्ट्रीब्यूट करो. Distribute protein evenly throughout the day would be the strategy for any renal patient. Okay, so एक साथ में 250 gram chicken मत खाओ. You need to distribute protein throughout the day. So next is the electrolyte balance. So potassium, sodium, and phosphorus. So how you can control the potassium? So here basically for hemodialysis patient, it is 2.7 to 3.1 gram per day, and there are the 3 categories. For potassium, there are 3 categories. 100 milligram would be the low potassium food, 200 medium potassium food, 200 to 300 high. So what will be the dietary counseling? So I told you that processed food, your pasta, your pizza, your packet food, they all are high in potassium as well as the sodium. Even concentrated juice, fruit juices, cheese, they are also so. So, how you can reduce the potassium? Actually, this guideline is very essential, not for you as a medical practitioner. This is essential for relatives. Leaching the vegetables. गूगल पे मिलता है ना लीच कैसे करना है वेजिटेबल्स को बट रियली ये फॉर्म में डू दे फॉलोइंग ऑल दी स्टेप्स हाउ टू लीच द वेजिटेबल्स peel and place vegetable in cold water, then slice the vegetable, rinse in warm water for few seconds, soak for minimum 2 hours in warm unsalted water using 10 times. एक कटोरी चावल है 10 times पानी डालो उसमें. Then rinse water under we rinse under again warm water for few seconds. Cook, and when you cook that particular vegetable, cook with 5 times amount of unsalted water. Then legumes. I hope you know what is legumes. Dal, jo legumes hai. So legumes may need to be soaked for 36 hours because it has a high content of potassium. So what are the food? They are rich in potassium. Banana, केला सबसे ऊपर आता है, and then avocado, dark green leafy vegetables, that is the spinach, methi, lima beans, sweet potato, broccoli, beet, and also nuts, peanuts, red meat. So ideally, it should be consumed in a very limited, and ideally it should be avoided for the ये सारी. Now food low in potassium. अभी सर आप बोलोगे वो क्या नहीं खाना है, तभी क्या खाना है बता रही हूँ. So low potassium, apple. Whenever patient comes, I hope everybody knows. क्या माइंड आँख बंद करके भी एप्पल पेयर पपैया चलता है, बाकी कोई फ्रूट नहीं चलता है. Okay. So moderate potassium mango. Now mango season is there. My patients are also asking, renal patient, can I eat or can I drink half glass of juice, half glass juice of mango? No. What happened? Once we allowed them, then what will happen? They keep on eating or drinking more. That is the main worry. If that person can control, then definitely person can have in a limited amount. Now sodium intake. So first we saw potassium, now sodium intake, and then phosphorus intake. So how we can control the sodium? I'm telling you that don't use table salt. Just control the salt. So what will be the salt substitute? You can use the roasted jeera powder. You can use the lemon. You can use the pudina and mint. Why pudina and mint over coriander? Because coriander is high in sodium as well as potassium. Mint chutney is low in potassium and sodium. And then choose low fat or fat free dairy product and read food labels. After this thing, I'm going to give just small talk on the nutrition labeling also, which is very important. This is regarding the sodium. So you are supposed to avoid the canned and packaged food. Now phosphorus. We saw sodium, potassium, now phosphorus. So when patient is on hemodialysis, it removes 800 milligram of phosphorus per session. That means 2,400 milligram phosphorus per week. So when person eats 1 gram per kg body weight per day, as recommended for hemodialysis patients, then person it will result in estimated weekly net balance of phosphorus of 2000 milligram. So what should be avoided and what should be consumed? So dairy products, as we know, all milk products high in phosphorus. So what will be the alternative? If this is the high phosphorus, this will be the alternative. So instead of milk, the way lactose intolerance patients are drinking the soybean milk, soy milk, almond milk, rice milk. So I can understand almond milk, rice milk, they are expensive. So that person easily, if non-vegetarian, can have the egg white. So rice milk, almond milk, cottage cheese, vegan cheese, and those are the important substitutes. Beverages, so again beer, then dark, जो आपके पेप्सी है पेप्सी उसमें ज्यादा सोडियम फॉस्फोरस रहता है एंड पोटेशियम बट आपका जो क्लियर है स्प्राइट है उसमें थोड़ा कम है बट इट डजंट मीन दैट स्प्राइट इज अलाउड आई एम जस्ट गिविंग द डिफरेंशिएशन so, plant-based foods are also contains organic phosphate, but they are less absorbed compared to animal foods. So this part should be avoided. And bread, rice, small amount of apple, and sago. See, renal patient can consume. Renal patient also need energy apart from protein. So sago it contains the zero carbohydrate. So sago khichdi. But again, if the diabetes patient, then of course we will not give the sago product. We will give the other product. Okay. So when person is on hemodialysis, certain micronutrients, as sir also told us that B vitamin, C vitamin, B12, they are lost. And already vegetarian people, there are zero source of food sources for B12 as well as, though I have not mentioned vitamin D. So supplementation can be given. Before supplementation, definitely for B12, if person is having a normal phosphorus level and potassium, can eat the curd. So fluid management, this formula everyone knows. Fluid management, urine output plus 500 ml. So 1000 ml per day will be your strategy. So these are the foods high in the fluid. So ideally ice cream, soup, watery vegetables like cucumber should be. So cucumber is allowed, but in a moderation. Monitoring. See, patient comes to me, I prescribe diet, and then मैंने diet दिया चलो हो गया. No, follow up and monitoring is very essential. Even over here also, when we are giving diet, individual diet plan, person needs to give follow up and monitor for all parameter as well as for food also. Whether person is followed the food, that's why we are giving food diary also. Okay. So these are the sample menu. I told you that I'm going to give the recipes and menus. So just a simple menu hai. If person can eat early morning light beverage tea but limited milk. Breakfast main meal 1 boiled egg white, 2 slices white bread with ghee. Ghee is an excellent source. Actually, ghee provides a good amount of fat. So person can eat at least 2 teaspoons. That is the 10 ml of ghee. One small apple or papaya. Mid morning. See, ideally, energy protein should be distributed throughout the day. So, mid morning, just light snack, kind of a poha, upma, one small ball, or a puffed rice, murmura. Lunch, you can have a 1.5 chapati, 1 cup rice. chicken person is non-vegetarian, chicken or fish curry. If non-vegetarian नहीं है, सोयाबीन तो सोया टोफू या पनीर वेज दे सकते हो. Okay, see amount is also mentioned. Amount is very important. I have mentioned the loki, gourd vegetables because they are low in sodium and potassium. And carrot salad. See, asterisk that means if person is diabetes, then instead of rice, you can ask person to eat either curd or salad. Evening snacks again tea, coffee in moderation, and puffed rice. Dinner again chapati and paneer or egg curry or moong dal or cabbage or katori. And on bedtime, 1 glass milk or 1 glass water with renal supplement. And if person is not on renal supplement, just half glass of milk is also sufficient. This will control the sodium, potassium as well as phosphorus in uh, malnourished patient, and it will also provide a high biological value protein. So ये करने के बाद में हमें क्या अचीव हो रहा है from this sample menu? So you will be able to giving 70 to 85 gram protein, fat also in a limited amount, sodium also limited up to 2200 milligram, potassium up to 2500 milligram, phosphorus 1000 milligram, and calcium. Though I haven't mentioned about the calcium, vitamin D, and there is no source of vitamin D in food. My PhD topic was also on the sunlight and menopause women. So sun ideally between 11 to 3% should expose for 5 to 10 minutes in sunlight, because when the sun is on our head, this 90 degrees, then only you will get the exact amount of sunlight. And then early morning 8 a.m. you won't get the enough sunlight and enough vitamin D. Without vitamin D, you know that calcium absorption is not going to be happen properly. Now dietary guidelines. So this slide specifically about the phosphorus, only phosphorus. Then limit the milk and dairy product because they are high in phosphorus. तो क्या करना है? So person will or patient will ask question, and even as a medical person or student also you will be asking, अरे suppose I am traveling, okay, I am not at home. This all thing is about the home cooked food. So मुझे तो कुछ पैकेट का खाना ही पड़ेगा. So what I can do? So now next slides, I will be just speaking 3-4 slides about the nutritional labeling, which is very very important. Actually, what do we read when we buy any packet? Any packet. आप वेफर का पैकेट या बिस्किट का लिया तो क्या लिखते हो?
Calories.
सर यूज बाय प्राइस सबसे पहले अरे कितना ग्राम भी नहीं देखते, प्राइस दिखा लिए एंड देन सर यूज बाय और बेस्ट बिफोर प्राइस एंड समटाइम्स कहां से बन के आया है, दैट्स इट. बट दैट इज नॉट sufficient even for normal person. Forget about the diseased person. See here the nutrition facts. So serving information, example like 5 rupees Maggi, which I told you that serving size, portion size, one serving आपकी जरूरत अभी सिर्फ 5 ग्राम 5 रुपए का मैगी पैकेट की ही है. ओके, बट अगर आप वो 3 स्क्वायर खाते हो, दैट इज आउट ऑफ योर चॉइस, out of your liking खा रहे हो, आपको बहुत पसंद इसलिए खा रहे हो. Okay, so it will end up giving you more calories. See the nutrition labeling, serving information, serving size 1 cup, calories. So ये 4 सर्विंग का पैकेट है. एग्जांपल मतलब आप 4 दोस्त लोग साथ में खा सकते हो, आप अकेले का नहीं है. बट वेफर एम्प्टी कैलोरी है तो हम तो अकेले खा सकते. तो हम क्या करेंगे, 4 लोगों की एनर्जी खा जाते हैं. ओके, सो 4 की एनर्जी, so 4 times of sodium, 4 times of phosphorus, we will end up eating everything 4 times. See nutrients, they have clearly mentioned nutrients, total carbohydrate, total sugar, that means of the carbohydrate product. Suppose wheat flour या यूज किया है, added sugar separately रहता है, they have added sugar. And see percent daily value actually which is very very important, हम लोग neglect करते हैं. So in that see 20% or more